Welcome everyone, and thank you for joining us in this extremely interesting webinar about higher education under examination. Are we ready to train the future healthcare workforce? I'm Albert Barberà, the director of the eHealth Center at the Open University in Catalonia, and I'll be the moderator of this webinar. First, let me introduce Professor Pam Fredman, President of the International Association of Universities, our host. Pam served as rector of the University of Gothenburg from 2006 until 2017, and she's a professor of neurochemistry. Thank you, Pam, for joining and hosting us.
Thank you very much. First of all, I would like to welcome you all to this webinar. It's an IAU series of webinars, and I'm happy that we are partnering with the UOC, one of the leader institutions for the IAU Global Cluster, focusing on Sdg3. The pandemic has shed light on the interrelationship between human, planetary, and economic health, socioeconomic inequity within and between countries worldwide. The pandemic have also shed light on the importance of the SDGs and their interconnections to empower societies to meet global challenges and to realize Agenda 2030. Universities are key actors and partners as declared by the UN. And today's seminar is focusing on how the universities takes on its role to empower today's and tomorrow's healthcare professionals through research, education, and training, and to serve the societies to reach the SDG3, ensure healthy lives, and promote well-being for all at all ages. We are still in the middle of the pandemic, but there are already lessons learned and future needs are highlighted. There is a responsibility, but also opportunities to rethink higher education. The universities needs to engage with the communities, improve and develop dialogue with the healthcare actors, and to act locally, but at the same time, always think globally. The SDGs are interconnected, and to ensure quality health service to all and at all ages, the links to several of them, the SDG4 education, SDG5 gender, SDG6 clean water and sanitation are some of those. The SDG partnership is essential, and the IAU Global Cluster is one example. And I would say that we need more cooperation, cohesion, and less competition within the higher education sectors and with external stakeholders. And from the survey of the COVID-19's effect on the higher educations performed by IAU, but also by others, shows clearly that there is an increased contact between academia and policymakers, politicians. A step forward may be to increase trust in the value of higher education in society and hopefully leading to awareness of the need of government support for higher educations. I would also like to make a short introduction to the IAU and the IAU Global Cluster. IAU was created in 1950, 70 years ago, to meet the pronounced need for a global community of higher educations and to present a global voice. It's a member organizations with more than 600 members of higher education institutions, organizations, and associations from 120 countries. It's an NGO, and it's still affiliated with UNESCO and promoting and advocating value-based higher education and its key role to contribution to society. IAU has actually for more than 25 years been active in working to advance higher education for sustainable development. In response to the Agenda 2030, addressing the complex and interrelated challenges identified therein, and with the aims to further promote and globally act for the role of universities, IAU created a Global Cluster 2018 on higher education for sustainable development. It comprised 16 thematic clusters, one for each of the SDGs, and SDG 17 is led by IAU and brings together higher education institutions, organizations, and associations, all involved in working on sustainable development. Each of the SDGs has a lead institution, and they are cooperating with up to 8 satellite higher education institutions from all around the world. The thematic clusters provides a platform with a specific focus on one goal, but also on the interconnection with all the others. And there are two concrete objectives for the cluster. The first is to serve as a resource and networking hub for higher education institutions around the world, for institutions that are already engaged in the SDGs locally and seeking partnership, and those starting to engage with SDGs and who turn to the cluster for collaboration and guidance to translate and advance SDGs in local, national, and international context. And the second is to serve as a global voice for higher education and sustainable development. And I actually advocates for this at the UN High-Level Political Forum, UNESCO, international conferences, and other events. And of course, Sdg3 subcluster is led by the Universitat Oberta de Catalunya. And before giving the floor back to Albert, I would like you all, members and not yet members of the IAU, to visit our website and to learn more about the IAU and its activities. And that includes also the cluster's activities and the weekly webinar series, as this is one of them. And I welcome you all.
Thanks, Pam, for hosting us again and helping to make this webinar a reality. Just a brief introduction about the Sdg3 cluster. This global cluster is led by the Open University of Catalonia and brings together the following universities around the world. It includes the University of Caldas from Colombia, the University Gadjah Mada from Indonesia, the University of Western Sydney from Australia, the Karolinska Institute from Sweden, the University of College Dublin from Ireland, and Makerere University from Uganda. As Pam said, it forms part of the IAU Global Cluster on Higher Education and Research for Sustainable Development. How we envision ourselves, our vision is that the higher education institutions became change makers for holistic and equitable health and well-being worldwide, with the core values that we think it's very important, and as we all agree, the COVID pandemic has really put on the table, which is health as a universal human right, equity, democracy, and inclusivity. When we were thinking about this webinar, as Pam said, we thought that there's many lessons learned from this pandemic that we are living that can help us rethink how we capacitate, how we teach, how we prepare the health workforce. Of course, it's not a topic that's a new one. I think there's been a lot of work about it, and I would like to mention a Lancet commission about it, since one of the speakers is part of that commission, and I think it's a 10-year-old paper, but it's still updated, and I think it's very interesting. So the idea of the webinar is, from these lessons learned, which is going to be different from different parts of the world, how we can translate them to the way we think for the future education of the professionals of health. So without further ado, I'll introduce the participants. All the participants have long experience in teaching in different faculties of medicine, of nursery, etc. And also they have experience with dealing with policymakers and governments, which I think it's another topic that's on the table nowadays with the pandemic. So our speakers are Titi Saviti, which is an associate professor in medical education at the Faculty of Medicine at the University of Gadjah Mada, Indonesia. Maria Niemi, assistant professor of the Department of Global Public Health and coordinator for Sustainable Development at the Karolinska Institute in Sweden. Also, David Serwadda, he's a professor of infectious diseases in the Department of Disease Control and Environment Health at the Makerere University from Uganda. And from 2003 to 2009, he was the Dean of the School of Public Health. And Virginia Schmied, professor of midwifery in the Nursing and Midwifery and Health and Wellbeing Think Champion at Western Sydney University from Australia. And finally, Marta Imaric, health science professor, and also Vice President for Strategic Planning and Research at the Open University of Catalonia. So we're gonna start with a general question for all the speakers, which is what are some of the lessons learned from the COVID epidemic that are relevant to how you work and teach? So the floor is yours. As you know, we have 4 minutes for each the speaker, so try to keep on time. And our first speaker is gonna be Titi Sabriti. Thanks for being here.
Hello, good afternoon, good evening, good morning. Thanks for the opportunity to join these sessions. COVID-19 has taught me a lot of things beyond what I can imagine. We know that now everything can be done from home. It saves a lot of time, a lot of energy, a lot of expenses. And also, due to this, we need to rethink again the meaning of full-time and part-time students. Learning can be more flexible at the student space, anytime and anywhere. This will also save a lot of money. Higher education become more accessible by those who previously cannot get access due to physical and geographical barriers. The role of teacher in this situation will shift to become a learning designer, learning monitor, and learning evaluator. Learning materials can become unlimited, especially when universities are willing to share their collections of learning resources, including teachers, experts, scientists, and practitioners. If they are willing to share what they have, their expertise, their knowledge, their experience to all over the world, learning can be for everybody. Combinations of courses among various programs within a university can be done, also among universities in one country or even among universities in many countries. In the future, distant learning, blended learning will become the dominant mode of learning. Greater cooperations and collaborations will be occurring more intensively and frequently. It is inevitably no institutions, no government, no universities can no longer work in silo. People have to change. People have to collaborate more. We also need to redesign and redefine quality assurance in higher educations when we change the modes of higher educations. I now realize the potentials of digital technology, which is unlimited. Teaching learning process can be more efficient, more interactive. Unconsciously, we have now more interactions with the students. And also for the teachers, they have more time to update their knowledge, their articles, and to share their experience with other teachers. Now we can see there are so many webinar forums on various topics, and most of them are free, and you can just join, although the organizer can be everywhere. International seminars and conferences can become more accessible because people can get access online, and especially from developing countries, they can now join the international conference because they don't have to pay for the travel costs, etc. So the purpose of medical education is to produce medical and healthcare workforce which will deliver healthcare. When healthcare is changed due to the advancements of digital technology, obviously the medical educations need to adjust as well. As the pace of changes is quite fast, it is important to employ medical curriculum which is more flexible, more adaptable, more localized. Competence-based curriculum is more appropriate, where the focus is on the acquisition of competencies. Medical doctors' competencies can be broken down into units of competencies, where each unit is a standalone course and can be mastered in a particular time. Students are not necessarily together all the time, but they can move at their own pace through units of competence as they move up the educational ladder. Thank you.
So, good afternoon. Good afternoon, everyone. Thank you very much for this opportunity. I think some of the points I'll make might differ a little bit in nature to what Tita has introduced to us, but thank you very much for that presentation. I wanted to say at the outset that equity and engagement with our community is really at the heart of the work that we did at Western Sydney University during the time of the pandemic, and that compassion and adaptability really shone through in many, many respects. Yes, of course, we had to turn everything to online learning for all health professional and others students during that time. But without the sort of local knowledge and understanding of our communities, we wouldn't have been able to do this as successfully. And this started really with the knowledge of the students. And we have quite a number of onshore international students and other local students who were suffering extreme hardship at the time because they lost their jobs. Some of the international students had no place to actually live. And so the university responded in a very compassionate way by building an assistance fund. I think that has really given us some insights to some of the most vulnerable groups globally who are experiencing the pandemic and what might need to happen. Our colleagues across the university and particularly in the School of Nursing and Midwifery, we have the largest program in New South Wales, the state of New South Wales, and second in the country. And so to turn everything to online program was a mammoth task, and my colleagues were, to be honest, quite exhausted by that. We will move to a more high flex model. It's being described as a hybrid model. The students will experience opportunities for both face-to-face as well as online learning. And we've learned from our students as well as from our colleagues that there are a range of preferences and different learning styles and different needs. So while we can gain a lot from online learning, and later on I'll talk a little bit about some of the research we've done around online service delivery. But the online environment has still meant that we have to produce clinical placements, and these were restricted during the time of the pandemic. So a lot of first-year students didn't get to start their clinical placements in a number of our health professionals. This is going to have a real cascading effect for us next year, and also for the health services who will be limited in the number of graduates. So we had to respond very quickly by finding ways to ensure that the graduates for next year would get the required competencies and the clinical experiences that were needed. And for example, the School of Psychology was able to offer psychological services online to clients, and that was a way of training students as well. Now, we responded very in lots of ways to the needs of our health service partners. So we're very embedded in the context of working with the health services closely. And for example, at one point, while our outbreak has been nowhere near that of other countries, there was a fresh outbreak, a second wave could have started, and our School of Nursing the faculty staff were called upon overnight to help with coronavirus testing. Now, a medical school, I think, offers a really important example of the capacity to respond to the needs of the health service during this time. So during the pandemic, one of our health services requested assistance from the Dean of Medicine because overnight, one department with 20 junior staff was suddenly in isolation out of a staff of 22. So the request was, how can medical students assist? And this is helping us learn differently now about how medical students and indeed nursing, midwifery, other health professional students can gain their experiences. So reflecting the participatory approach at Western, the first step was in the School of Medicine was to discuss this need and the initiative, the idea of assistance in medicine with the students who are due to graduate later this year. And how did they feel did they feel prepared to work as an assistant in medicine? So the program got off the ground very rapidly. The initiative worked well. The students gained a lot from the experience. And importantly, Professor Anne-Marie Hennessy, distinguished Professor Anne-Marie Hennessy, who's our Dean of Medicine, said this was for lots of reasons. And I think these reasons are really important for taking us forward in health professional education. And that is, there was agreement at a systems level, both national and state level, that this was a priority. So when you get this appetite for a change in model and approach, it can be done, particularly when the policymakers are on board. The university and the students were held in high regard, again, making this possible. There were existing systems and a model to follow. So nursing and midwifery both have assistance in nursing and midwifery programs that were already legislated in our state. The students have a strong voice in the program, and communication was key. New models of training like this, we hope to be able to maintain something like the Assistance in Medicine program. The students were paid for that work as well, which obviously can give our students a great income during that time. So just to sort of finish off, going forward in terms of education, this community engagement and embeddedness has been absolutely critical to the work of our university and to health professional students. And we need to ensure that the community engagement and co-design principles are part of health professional education going forward. We also need to really always have front and centre out that Indigenous knowledge and experience must really be at the centre of the programs that we develop going forward. Systems change internally and externally is still needed to build interprofessional education, and we would relish the opportunity for that not just to occur across our university, which has been quite difficult to get off the ground, but also globally. And while the education of health professionals at Western is really embedded in the community, our local community, we'd like to look much more forward to the global community. And just to finish, I wanted to say that the most vulnerable in our communities across the world have been the most affected by COVID-19. And going forward, we need systems thinking to address the significant health needs, not just the health system, but social protection systems, food systems, water and sanitation systems. And the SDGs, Sdg3 and all the SDGs are at the heart of this work, and we need to ensure that they're embedded in our curriculum. Thank you.
Thank you.
Thank you very much. Thank you very much for having me to join with you and share some of our experiences, particularly how COVID has really changed or transformed education, health professional education. I come from a region of Africa whereby epidemics, it's a panacea for epidemics. We have had, that's the Great Lakes in Central Equatorial Africa. We have had many, many epidemics, Ebola, Marburg. Every year we have a cholera epidemic. HIV has really, in the last 30 years, devastated a part of our world. But most of these epidemics, I would say, as far as training is considered, they have had consequences. They have been consequential in terms of how we train our health professions. COVID, however, is very different. It's going to be transformative. It's already proving to be transformative in terms of the way we teach health profession. So it turns out that as a member of the Lancet Commission on the education of health profession in the 21st century, we've envisioned IT platform as a major force in terms of training, both in terms of empowering the student and the teacher to interact not only locally, but also globally, so that students can be able to have a forum in which they can actually learn among themselves, but also be exposed to a consortia of other learning institutions across the world. And we envisage that this is going to be a huge catalyst in empowering and having students continue to learn through their life and being able to form a global student or global teachers in terms of imparting knowledge. Not only that, but also disseminating information. I had in my wildest dreams, I could not believe how COVID could really transform, catalyze the speed at which e-learning has actually been established in my institutions. As you know, health professions tend to be very conservative professions. People hardly want to change methods of how they train or how to do business. But I would say COVID in my institution has had institutional changes, rapid institutional changes, and very rapid instructional changes in how we deliver our training. I mean, the government of Uganda was able to take on, through the Ugandan National Higher Education Council, to actually formalize e-learning or online learning as a medium of training. And all higher education institutions in Uganda had to actually embark on that within a very short time frame. Many institutions had to scramble. To be sure, there was already some kind of impetus, we were already moving in that direction, but the speed at which COVID was able to really enable us to move at a very fast trajectory towards e-learning was extraordinary. So e-learning is already established in many of our institutions, and we have been extremely very innovative to try to make sure that we can deliver the materials that we can. And because of the necessity, all obstructions that I used to hear, were not there. So, however, e-learning in our part of the world has great opportunity. It has a way of leveling the levels. It is the access of material wherever you are or in different institutions. So it has a way of leveling the ground. But it also does bring out the disparity already, structural disparities that are already in place. Ability to get internet is not geographically well distributed in the country. There are pockets, especially in the rural areas, that are not. So students who are caught home or while leaving home, not all of them can easily access this platform. The other issue is that even those who can, ability to get data to be able to access this material is extremely expensive overland. Many of these are students coming from rural areas. However, I see these challenges that tend to expound or exaggerate the disparity that we have as a great opportunity for the infrastructure, for government to really put emphasis on infrastructure and being able to actually make sure that data is much more accessible, especially in institutions of learning, as a priority. So the need and the demand has been established, and I think the resources have to be made available. One interesting thing that we experienced in our institution as a result of COVID is that many of our students weren't able to go out and collect data, especially graduate students, that they need to complete their educations, to generate thesis or papers for them. And this suddenly created a huge need to do secondary data analysis. There's a lot of people who have second data they have collected over the years. And therefore, secondary data analysis created or opened up a huge debate on the fact that the university did not have a data sharing policy. But they have seen that there's a need to actually utilize ongoing collected data to be able to actually get the most out of the data already collected, either public data or individual researchers' data. And as we speak, our university is really trying to put together data policy, sharing policy, whereby actually data collected through various investigations can be made available to be able. I think this would be a great way of teaching students, because much of the data is collected and it's not utilized, and also make access to actually writing papers much easier as opposed to primary data collection all the time. And I think that that is going to be a very important way in terms of really utilizing all the data available.
David,
lastly,
try to sum up.
Yes, so I think in summary, COVID, unlike many other epidemics that we have had in our part of the region, is going to be truly transformative in terms of the way we teach, as opposed to any other previous epidemic that we have had. Thank you very much.
Thank you.
Hi, I'm very happy to be here. So thank you very much for inviting me. So I will say that 21st century starts in 2021. I think the first 20 years were the preparation for the new century, or put it in other words, COVID-19 accelerated changes that were already in the making. Besides what previous speakers had mentioned, I will refer to the need for interdisciplinary and interprofessional education, as well as the need for community-based healthcare and soft skills in the curriculum. For interdisciplinary education, I mean specifically the links between epidemiology, public health, and planetary health. As previously seen with SARS or MERS, close contact between wild animals and human beings allowed the SARS-CoV-2 to cross between species, leading to the appearance of new human disease that quickly spread around the world. So, preventing transmission of viruses from wild animals to humans involves stopping the extinction of animal species and preserving biodiversity and natural ecosystems. We need to imagine solutions for the whole planet that are ethical and, moreover, not just for one of the species, that is, humans. Climate change affects every aspect of our lives, from the air we breathe and the food we eat, to the increased risk of epidemic diseases and natural disasters, and the social disorder that these crises cause. After the COVID-19 crisis, we should adopt a planetary health approach, since protecting the environment is an essential strategy for avoiding other major health crises. We should intensively learn this, from medical schools to continuing medical education. Therefore, interprofessional education with public health and environmental sciences is a must. Interprofessional education with nursing and other health sciences is also a need. Teamwork is essential for healthcare delivery, and the sooner medical students interact with other healthcare professions, the better. In addition to that, we will witness a service transformation for sure, from hospital-based to population-based care. That means a community-based approach in the medical education curriculum, without forgetting the patient-centered health, or citizen-centered health, if you will. We are transitioning from seeing a patient as a passive complier to a citizen as a co-producer of well-being. Finally, I'm also advocating for data sharing and open science. I hope that from this crisis remains that all scientific publications should be open access. Now more than ever, it has become clear that this is a must. We need knowledge, scientific research to make decisions, and closing papers doesn't go in the direction of contributing to making the most appropriate ones. However, we all know that scientific research lives in the realm of uncertainty. What is true today may not be so tomorrow, because it has been overcome or even refuted. In addition, there are some discrepancies between the studies. The discrepancy between scientists is not at all strange. Rather, it is beneficial. It can lead us to different results that may be more appropriate to meet a given challenge. It's not about believing in science. It's about taking it into account. Scientific results help us making decisions, but they don't tell us what to do. We all know that making decisions in conditions of uncertainty is very difficult. The pandemic makes it clear to us and in real time. Therefore, how to deal with uncertainty, as well as about open science and data sharing, should be taught in medical school through soft skills. Thank you.
Hello. Also very grateful for the opportunity to be here and talk about these important topics of how to move higher education towards sustainable development and contribute more to the SDGs through higher educations of health professionals. From my perspective, and adding on to many of the things that have already been said, but the COVID pandemic has really made the weaker links of the healthcare system visible. So one way in which this one weak link that has become very clear from my perspective is that the difficult medical decisions and priorities that healthcare workers have been confronted with during the COVID pandemic have led to increased moral distress and stressful working conditions, as well as the long shifts and lack of adequate protective equipment have really made it visible how these aspects of health worker preparedness for uncertainty, as mentioned by Marta here, is something that we haven't really been focusing adequately on in medical education. And the health system, as it looks now, has put health workers at increased pressure, where they haven't been able to keep up pace with increased demands on becoming more like technology managers and administrators in healthcare systems, where soft skills have kind of not been prioritized. And this also adds to risk of moral distress and burning out, and also health workers leaving the professions. So something that the current pandemic has forced us to do is to take lessons from health workers and researchers who are more used to these kind of challenging situations, such as working with disaster medicine and seeing how we can take care of health worker needs for well-being and sustainability in the long run, even when confronted with difficult uncertainty and so on. So we need to teach skills for confronting uncertainty and also for systems change. So we need to train health workers to become change makers, also to implement change in rapidly changing circumstances. And also we need to take inner and transformative aspects into account in our medical curricula. So we need to train health workers to increase their inner capacities, collaborative capacities, and change-making capacities. And I'd also like to echo and really emphasize the importance of the already 10-year ago Lancet Commission for Educating Health Professionals for the 21st Century, where Professor Serwadda here was a co-author. That already then 10 years ago, these things were highlighted by the Commission. And now the COVID pandemic has really made it clear how we cannot turn away from the importance of these transformative skills in healthcare education. So we've been integrating this into our curricula increasingly, and of course this is something that needs to be taken into account when we use digital education, IT and online education increasingly now, that how to combine the need for increased education in collaborative skills and soft skills and so on, whilst using also more e-learning. So that's an equation also that will increasingly need to be solved in the future. So thank you.
Okay. Thank you, everyone, all the speakers, for the interesting comments and reflections. I think it's very fruitful, and it could link to a lot of time discussing about them. And I want also to remind to the audience that they can already place questions on the YouTube chat. So we have people like collecting the questions, and finally we'll have some time for Q&A. So just I think there's a lot of questions can be raised from all the things that the speakers have said. So just put them on the chat and we'll deal them with later. So now I'm gonna make some from all the things you've said. I think there's some interesting issues that I wanna address personally. So I'm gonna just launch some questions and address it to the speakers. So my first question is to David. So how do you think that the medical schools can become more prepared to train healthcare workers in dealing with a pandemic? As you said, you're living in a country that's had a lot of pandemic strikes. So I think your experience can be very helpful, how we think globally about how we prepare them. Thanks.
Right. To some extent, my answer or my response is going to be a combination of what everybody has said. My part of the world is a panacea for epidemics. We have had so many epidemics in the last 20 years, and they are increasing in scope in terms of the number of types of epidemics and the geographical footprint of the epidemics. So actually, our curriculums have actually been changing over time. They have been mainly both in terms of instruction, methods in which we do, and in terms of our institution. First of all, the first thing was we changed our curriculum to be able to train our health professions through a system, a healthcare system. The old panacea of training health profession in health centers of higher learning, either university hospital or teaching hospital, meant that we have to change actually the way we train right from the primary to be more cognitive of the fact, to be nearer to the community. Most of these epidemics will start from the community. You have to have your relationships with the community and community awareness and education of the communities about epidemics has to be inculcated into your curriculum. Secondly, we need to make students aware that epidemics are now not only local or regional, but they are international. When you hear an epidemic in West Africa or an epidemic in Middle East, you should be very clear that this epidemic can actually be, you can be actually facing it without you realizing it, because people move. So these are extremely important, regional, national, and international. So people, curriculums, people, our health profession have to be attuned to the fact that what appears to be a local problem can actually be staring at you 1,000 miles away. So there's a need to increase sensitization of the health of the training population about epidemics. The other thing that many of our epidemics have taught us, that actually primary health care and prevention is extremely very important. And the COVID epidemic has actually brought this out much more. When you do not have any treatment, the simple primary health care are extremely as important as anything else. I mean, look at a cholera epidemic. Look at typhoid epidemic. We still use clean your hands, wash your hands. Same thing as COVID. These issues that are so simple are extremely very important. And I think we need to really emphasize the need for primary health care. The last point I wanted to say is actually, Mariam did mention it. You work in a health system. The prevention, care treatment, and all different disciplines actually are very important to bring to bear in managing an epidemic, especially transdisciplinary interactions. People who are necessarily, well, you know, the finance people, the finances, people need money to do these epidemics. You have to interact with a lot of people to bring together a system to actually understand an epidemic. Students have to understand that complexity. So curriculums have to change in the way we deliver, and also the institutions have to change in terms of the medium in which we give these instructions. They have to be throughout the whole system, which is very clearly what the Lancet Commission really envisaged in the 21st century. This COVID has really helped to bring to bear some of those ideas that were very well articulated in that Lancet Commission. And that is exactly what we have been doing in our part of the world. Thank you.
Thank you, David. Very interesting. And I have another question for this one for Maria. I think some of the speakers have raised the topic about the soft skills. So are the soft skills the new hard skills? What needs to happen for them to get them more integrated in the curriculum? I think we've been talking about soft skills for a long time, and it's been difficult to clearly include them in the curriculum, no? Since we see them as something soft. Maria, your insights, I think they're going to be very helpful.
Yes, thank you for that important question. And indeed, I think mainly and largely due to our increased focus on hard skills and knowledge and change that can easily be quantified, we've kind of thrown out the baby with the bathwater. So soft skills are not as easily assessed, and that's partly part of the largest part of the reason why they've been thrown out also of siloed curricula. So there are three ways in which, or three levels in which I would advocate that they should be included into curricula. For example, the first one being leadership education. So as mentioned by David, interprofessional and transprofessional education, breaking down these kind of silos is very essential in this regard. And also having students collaborate in non-hierarchical constellations. So this will advance their group teamwork skills and leadership skills, which is very necessary for inducing these kind of skills in the healthcare service and healthcare system. A second perspective that needs to be more clearly integrated in curricula is the systems perspective. And here as well, we've kind of thrown out the softer sciences, so to speak. So social sciences, humanities, ethics. Students need to be confronted with the notions of social justice in order to be able to understand health in the broader context of a systems perspective, and to also enable collaboration with important networks and stakeholders in society. So that's another aspect. And the third aspect is bringing this down to the actual collegial and teams and groups and individuals working in the health system. So I advocate that we need to teach them ways in which they can promote their own growth and coping mechanisms when confronted with uncertainty and when confronted with moral dilemmas that are kind of baked into, for example, these kind of pandemics, but in health work in general. So there's ways in which to do this. For example, there's concrete ways of after-action review dialogues that can be used at health work at the workplace. So collegial support and team support and so on. And then just on the individual level, teaching grounding and stress reduction practices, self-reflection abilities, so that students can actually know themselves how they're coping in real time, so not having to risk burning out and leaving the profession. So the three levels here: leadership, systems perspective, and group individual perspective are ways in which soft skills I think should definitely be integrated. Thank you.
Okay, Thank you, Maria. I think it's very interesting. Now moving to e-learning, and I think many of you have also pointed out that's been one of the consequences from the COVID, that we all had to change to tools using telemedicine or using online teaching, etc. So Titi, do you think that remote teaching and learning has come here to stay? And how you think that will medical schools need to change to adapt to that challenge? I mean, and with the clinical competences and practice, etc. No? And also, what opportunities do you think that this bring to the universities and the schools of medicine and nursery in particular? Thanks.
Okay, thank you. First, this COVID-19 pandemic taught us about the situation that we face: disparity, inequity, maldistributions of health workforces. We know that there are equity of access, and we know that in many parts of the world there are areas, villages, rulers that are underserved. So I think this COVID-19 pandemic taught us that we need to expand the medical education. In many places, in many countries, medical schools are located in big cities, in the capital cities. This has pushed us to recruit students from the big cities, limiting or reducing the opportunities for students from the rural areas. So now we have realized the power of digital technology, where we can expand the medical education into remote teaching and learning. So I think in the future, this will become the main mode of medical and health profession education. Secondly, medical schools, health profession schools need to become more socially accountable. They are not just producing graduates and then that's all. No, they have a mission that they need to serve the health needs of the populations that they are mandated. And therefore, they are also obliged to ensure that health workforces or medical workforces are accessible by those who need the access of healthcare. So we need to optimize the use of digital technology in delivering the medical and health profession educations. Is it possible? Yes, it is. We can develop virtual medical educations. We need to become more innovative in using the e-learning approaches. We need to adopt the new learning technologies, especially the use of virtual reality, the use of artificial intelligence, and other advanced instructional methods. And lastly, we also need to think of adopting what we call distributed learning. It is a model of instructions where the instructors or the teachers, the students, and the learning contents could be located in different non-centralized locations so that teaching, learning, and instructions can occur independent of time and place. So therefore, learning can occur in remote places where healthcares are most needed. So in employing distributed learning, we need to really make use of three things, three components. That is the use of technology. We know that now the digital technology are very advanced. A lot of a lot of technology that we can use, such as LMS, learning management systems. We have a lot of social networking technologies, mobile learning, etc. And also we need to use to optimize the collaboration of people. We need to improve the collaborative learning. This COVID pandemic also taught us that we cannot work alone. We need to increase the collaboration. We need to work together. So we need to embrace collaborative learning. By having distributed learning, we can maximize the interactions among the students. We can develop communities of practice. Also, we can develop the networking between students, student teacher, and also students and the communities surrounding them. So I think in the future, we have to be prepared to think out of the box, to think in a totally different way of learning, to really push more the learning to occur outside the class, but learning to occur in the community, learning to occur close to the people where they need to be served. Thank you.
Thank you very much, Titi. And linked to this change that we've seen, and as I was saying before, I mean, COVID has increased the telemedicine use, since it was an easy way to deliver healthcare in this situation, especially when the hospitals and other healthcare dispositifs were overloaded with patients and etc. No, so Marta, how do you think that medical schools need to change to adapt this technology? I mean, I think ICT is becoming more and more present in the way we deliver healthcare, and I'm not that sure that in the medical schools or in the nursery schools they are aware of that. So what do you think is going to happen, and how COVID, quoting David, can be used as a transformative opportunity for that?
That's the most important question. I don't know. I mean, we don't know for sure all the pandemic's implications on medical education. But I think, like you're saying, that health professionals will have to train much more than they did so far in digital health. For instance, a healthcare workforce need to know in depth medical apps in order to prescribe the most effective one, and as well as to know how to use social media for health promotion, or using health data science for making medical decisions. So one way to do so is, as all my colleagues have mentioned before, is to use ICT in education. It's something that you learn by doing, and so online learning, I think, should be embedded in health education. I know for sure that any health degree hardly includes specific training in digital health. It was raised by by other speakers. So since knowledge is growing and growing, we need to be innovative in our education. So problem-based learning is one way to do so. Using ICT platform is another way, and being all the time aware of the new innovative education skills and technology that can be out there. So medical schools, in a way, should be lifelong learning health schools. Thank you.
Thank you, Marta. And now also linking to the ICT and the impact on equity, I think that from what Virginia was saying, from their experience with the community and with dealing with the social groups, that they really strike really badly with the pandemic. What kind of issues do you think that ICT brings as a means of delivering healthcare in relationship to equity in access to healthcare? So Virginia,
Yeah, thanks much. Yes, I feel like I'm exercising in my mind a lot of a level of caution. There is some, absolutely into the future, fantastic application of ICT, and a lot of that is there now. I mean, but even in Australia, we struggle to provide internet access and relatively inexpensive data to people. So now at the moment there are a lot of services were cancelled in the communities. I work a lot with maternal and child health and with health workers providing services to those who are more vulnerable. So during this time, there was a switch to telehealth in our community services, so in our maternity care and because we didn't want people coming to appointments. This meant that in some instances, particularly women who might be from migrant and refugee backgrounds, our Indigenous First Nations women and mothers and families, those who have got lower socioeconomic resources, sometimes just, couldn't actually make those appointments online. The majority of our telehealth services were provided by phone, which is a little bit old-fashioned in a sense. Indeed, somebody told me the other day that, in fact, the nurses, and this was great, but they actually reverted to also sending things via the post to families, so information and resources rather than email even, because of lack of access. So we actually in Australia have a long way to go to be able to have this moving. This has pushed us in a really rapid direction, but I think we saw a lot of the work when we think about our health professionals who work. All health professionals work in a relationship-based way, but in some of the work that we do, the actual therapeutic work occurs in the context of, if you like, talking therapies, or in the context of that relationship. So our technology, even with video chat, needs to be at a much higher level to be able to deliver a service. So a nurse doing a home visiting program to vulnerable families takes in all sorts of elements of the environment in home visiting. Home visiting has a whole nature in of itself. So only being able to access, even using a video chat platform, they can certainly see the environment if the family are prepared to walk around and show them the environment, and they can have conversations about what they might be cooking or what might be needed. But it's never going to actually replace in that context that sort of support that might be needed. We know from midwives providing maternity care that, in lots and lots of instances, this was preferable for women when they didn't have to come to a hospital service so often. But why are we still insisting that women come to hospital services in the first place for a well pregnancy? Why not in the community or in their homes? And what we learned was it's the mixture, so that using a range of telehealth options, whether that's video chat, whether that's actually just the phone, that flexibility is really important. And the most important thing we've learned through all of this is that when these systems work really well is when there's a relationship, so that they've actually formed a therapeutic or a relationship and will be seeing each other again. Then the ICT technologies work well. But otherwise, obviously, we have lots of women, families, elderly people living in remote communities, also not able to access services. So I think it's what works for whom and in what context. And we really have got a lot more to learn about it. It's inexpensive in lots of respects, except for providing our communication technology in Australia, it seems. And it's expedient, but perhaps it'll never be the same as that physical or mental health examination with all the human qualities of judgment and communication. And I know all of that is happening in terms of artificial intelligence, but is it, and will it be, be the same? And what is it about humanness and compassion and ethics and care? So I think there's loads of potential for student teaching. I took what Titi said at the very end there. We need to have our health professional students in the communities side by side with the people that they need their services.
Okay, thank you, Virginia, a lot. Before the question and answer section, I have a really quick question to each of you. You only have 30 seconds for it. I think there's been a lot of issues that raised, from e-learning to the community base, to the soft skills, to the way we transform. So if you had the policymakers in front of you with the magical wand that they can change the curriculum, which would be the #1 topic that you will tell them? So that's why you only have 30 seconds. So it's just one topic. From all the things, from all the lists that we said, which one you would say it's the first one that they have to address from a curricular perspective, of course. I don't know, we can use the same order that the first round table. So Titi, if you want to start.
Okay, thank you. So my first priority is to move towards socially accountable medical and health profession educations using the pentagram approach endorsed by the WHO, where all the stakeholders, the district health offices, the community organizations, the medical schools, the hospitals, all are working together to serve the health needs of the populations in that area. So social accountability is my priority. Thank you.
Okay, thank you. Virginia?
I would say, thinking from the perspective in my head of nursing and midwifery, I would say digital literacy, and in the context of interprofessional education, so picking up on Titi's point, with the skills to actually work with communities in a collaborative way, in a co-design way. So lots of the same elements there, I think. Yep.
Okay, David?
I'll have a different approach. I think 1 minute with the policy, in my part of the world, we need to invest. The knock-on effect investing in infrastructure, IT infrastructure, is going to be beneficial both for the learning, but also to our clients, the potential patients, the community. So infrastructure development to reduce equity of distribution, making data more cheaper is going to have a huge knock-on effect on health, wherever you are.
Thanks. Marta?
So since we are a team and we are a team together in front of a policymaker, I will take all the previous and also Maria's priority, and mine will be adding to digital health to this medical school. Thank you.
Thanks, Maria.
Yes, thank you. I think a priority here as I see it, is to really find great ways to collaborate, for example, within this cluster. So learning from each other, the ways in which we successfully integrated, for example, teaching these soft skills, so to speak. So leadership skills, transformative skills, educating students as change makers, like actual really hands-on ways in which this can be done, both in face-to-face learning, but in digital learning, taking into account also what Virginia mentioned here, really the challenge of sometimes using digital technologies when we're talking about soft skills such as empathy and relationality and these things that, well, there's a little barrier there in just using digital technologies for that. So how can we overcome and how can we bridge those needs and learn from, so co-learning, we have an enormous amount of collective experience here that we can really learn from each other. So knowledge sharing is key here.
Okay, thank you. So I think it was very interesting, and I think also that we kind of share this perspective of global and local. No, I think the things that the COVID pandemic has raised everywhere, and it's important everywhere, but there's also difference, and I think that's very enriching and fruitful for all of us. No, that this community, of course, the community needs in each country or in each region is going to be different. So it's normal that the university as a player in a community adapts to these necessities. No, as Titi was saying, the social accountability, which I really like. So let's start with some questions. One of the questions that we have from the audience, and I think we're still on the policymaking wall, which I love, is how do we get the policymakers on board to the change of the agenda mentioned during this talk? So I don't know, I launch it to you all, whoever wants to go on the floor, especially the ones who had more relationship with the policymakers. I think that's, and that's another, I mean, I know it's not the focus of the webinar, but I think that's another interesting issue that the pandemic have raised. That's how we deal, I mean, the universities and the researchers, how we talk with the policymakers. So I don't know, David, Marta, or whoever.
Right. I think, as I pointed out, the policymakers mostly understand cost benefits. So we need to generate evidence that actually going into a digital platform is going to, access education much more equity, more people will have access to education, it will be cheaper, and therefore we can be able to train more people. The fact that investing in the platform has a knock-on effect, not only in education, but also in the whole healthcare system, including the opportunity for patients to access healthcare through a digital platform. So I think trying to give a socioeconomic benefit onto this argument through evidence is going to be extremely very important in trying to sway why the role of actually increasing digital education is going to be a win-win situation.
Okay, thanks. Titi, I think you were
Okay.
also...
Yes, when we talk about the policymaker, inevitably we have to go through the political process. We need to engage with the political process through the political party or to other political pressures. But in another also way, we can use moral force. What the university can do is to have a moral force to provide the policymakers with the right perspective, the right way, the right solutions of how to deal with the problems. Thank you.
Okay, I don't know if somebody else wants to say something about this topic about how we deal with policy, Maria.
Yeah, I can say just from my perspective from the academic perspective, in order to kind of improve the interface or communication of science towards policymaking, we need to also think about the incentives within universities. So what is incentivized for us working in universities? Now it's mainly scientific publications and sometimes teaching, but even less so. But this communication of one's research findings in terms of contact with policymakers, policy briefs, writing more brief reports for broader audiences is not something that's incentivized within universities, and that's something that we can work on locally in our higher education institutions to increase that type of activity.
Okay, thanks. I would add, because I was reading the other day an article about the Spanish philosopher, which I love, about this issue that, and this sentence I really love, that he said that neither the politicians can do it all, nor the scientists know it all. So I think we have to be aware that we don't know it all, and also that they cannot do it all. And I think that's he's a philosopher about complexity and how we deal with complexity. So it's really interesting. We have another question, which I think it's quite interesting. Since we were talking about collaborations and this interprofessionally, one of the questions from the audience is how we encourage this collaboration between sectors, especially because they say that during this pandemic, there's been this kind of like competition between economy and medicine, no? The politicians, at least this sensation, no? That what it's more important to keep the economy going or the citizens safe, which I think it's not that true, because we can see it around the world that none of the solutions have been perfect. But I think it's a quite interesting question about this professional intersection and being medicine, as David said, that this cost effectiveness and talking with economy. So I think we literally going beyond what we think about interprofessionals. So it's not only medical and nurseries or other healthcare professionals, but going beyond other disciplines like economists. So, Marta?
Yes, well, that's real life. We deal with these decisions combining different the complexity that you mentioned before. We have economy, we have health, and both and all of them are interlinked. If we are ill, we cannot work, we cannot sell, we cannot buy. So we need to combine this kind of trade-offs between measures that we take. And we should be trained as in real life. So we should have some subjects together with other professions. Yeah, of course, health science, but not only, as I mentioned, planetary health or public health or environmental sciences are very important. So we need to know the perspectives. Only in that way we will be able to balance our decisions, taking into account environmental, the human beings, also other animals in the planet. And so together in a university there are several faculties. It's not that difficult to mix, and if we go online, it's even easier to mix students, and to go also in the communities, as Virginia stressed all the time, is another way to be in the real world, and we have to learn how reality works. Thank you.
I'd like to add on one thing. This goes back to the way we train health professionals. If in the process of training health profession, you are not training them as interdisciplinary and transdiscipline, when they come out, they will also not think that way. They will always think in their silo. So I think this goes back to the fact that our medical training has to change. So you nurture health professional right from the beginning to think that, you can actually work on learn as interprofessional, and also as you grow up in your training, work with other profession. That is how when you come out, you're actually likely to think that way. But if you're not trained that way, you're not going to think that way. So those are the important changes that we need to make in our curriculum. For example, when I was a medical student many years ago, I didn't think that journalists or politicians have anything to do with health. I mean, as long as you learn your medicine, you sit down, you look at your patient, you can change the world. It turns out that journalists, I wish I had more contacts. I knew how impactful journalists can be in my training. So that is the kind of thing we have to inculcate into our health professional, like from the training. And then we shall expect them to think in terms of across disciplines when they grow up.
Okay, thank you for your comments. And I have another question. Titi.
Yeah, just very quick. Health is a fundamental human right, so it is the responsibility of every government to ensure that universal access for healthcare is guaranteed. Good health and well-being is one of the sustainable development goals. So we need to have a radical transformations to put population health needs at the center of health profession educations, and to put health outcomes as the crucial component by which the educational process is assessed. Thank you.
Okay, thank you. I have another, I'm gonna bring together two questions just to keep the time, since we all have busy agendas, which is more or less linked to e-learning. So what do you think are the main barriers for e-learning in the medical or in the healthcare professionals? And also if they can help us on the practical sessions on how we teach the clinical and all the healthcare capacities. I mean, how, since we are mainly used to do that on presentially, how do you think that they can help us to train the medical and the nurseries and midwifery and all the professions of the future? I don't know, whoever wants to join the floor.
Yes,
Virginia.
Virginia here, just thinking about you know, e-learning in general. It's not just necessarily about being, you know, on an online platform engaging with others through Zoom, whatever, which has been met, I think, with a range of different success depending on the size of the group on board. But it's how do you motivate and engage using diverse learning technologies and innovative approaches that really bring you know, students from different professions together to, you know, problem solve and to think about health in the world. So, and that's not particularly giving any answer to anything, but it is, you know, we work in very time-pressured environments, and it's really hard to meet the levels of innovation that are required to engage students. You can see there are some real opportunities for that, but motivating and keeping people engaged in an online environment is, you know, I know that can be quite exhausting for my colleagues and myself.
Okay.
So looking for answers here.
Somebody else or?
So,
oh.
So we need institutional changes, meaning institutions have to change to mandate e-learning, but also to provide a training platform in terms of increasing the availability of or putting together the infrastructure that you need. But there has to be institutional changes. And then once that is there, like now in my institution, there are institutional changes that range right from the Ministry of Health, the Ministry of Education. We have no option now. Now, also then, you have to make sure that your curriculums are gradually, I know this is going to be a process as opposed to just a one-time event, are shifted to be able to be friendly to have e-learning. There is a particular challenge, especially in medicine. It's an apprenticeship. It's a very hands-on, you know, in your face training. But I have seen new platforms, new instructionist procedures now, whereby actually people can actually learn from a distance through, you know, people doing an operation, and they can be actually participating in that operation at a distance. So I think once the infrastructure is put in place, I think people are going to adapt. But I think what actually COVID has done, it is my experience that health professionals are very resistant to change. As Mata has said, you know, e-platform learning has always been there. You know, we've been moving slowly, but there has been some, you know, in Africa, there's a saying, it's very hard to become left-handed in old age. There's been a resistance. What COVID has done is basically give everybody no choice. I think that has been the biggest hurdle, especially in the other profession. And I think now this is the enabling environment to be able to do this. But both institutional motivation and instructional changes are going to be a very important way to catalyze and propel this method of learning.
Okay, thanks. Pam, I think you wanted to add something.
Yeah, I'm not the panelist, but I would like to raise one thing that hasn't been raised, and that is we're talking all the time about how to change the curricula in the healthcare education, and we're talking about the healthcare sectors or faculties. So why don't we think more about those being trained from the beginning in IT or whatever, and then get also the competence to act in the healthcare sector? So we bring broader competence and see other competences coming in.
It's really interesting. Thank you, Pam. I don't know if you want to add something, which is a completely different perspective.
Just to add one more, I'm thinking a little bit wild. You know, we can develop a learning ecosystem everywhere. We always think of learning takes place in the main teaching hospital or in the campus or in the clinical skills lab. We have community health centers in many places. We have GP practitioner. So, for example, during the COVID, because the students cannot go to the campus, they can learn through these, community health centers in their neighborhood. He or she can learn with the GP practitioners in the neighborhood. So we need to maximize the learning. Again, that distributed learning means try to develop learning ecosystems everywhere. So learning is not confined only in the campus. So it can happen anywhere, any place, at the pace of the students' choice. Thank you.
Okay, thank you. Since we are reaching the time, I don't know if you want to add something else or we just move to the closing. So feel free if you want to add just last one comment, or I'll do the closing with Pam.
Just one thing. Everything that you can teach in a classroom, in a face-to-face classroom, it can be taught in an online platform. That's for sure. That's true for sure.
Okay,
yes,
thank you.
Just one more. I agree with Marta that using e-learning or blended learning, we can achieve the same competencies as using traditional face-to-face. So we are not supposed to be in doubt for this. Thank you.
I'd just like to add one last point, and that is to Titi's point. When you look at the history of medical education over the years, actually it's not the medical profession that have profoundly changed medical education. It's actually people from other sector. When you look at the Flexner report that revolutionized the medical training, especially in America, it was actually by Flexner. Flexner was not a doctor or a medical profession. He was actually an educator. And to Pam's point is probably in terms of trying to find how we can accelerate this, maybe we need to listen to educationists, we need to listen to people from IT background. Basically, we need to bring other profession to be able to be surprised that they could make much more impact in terms of the way we can teach in these e-learning platforms or medium than actually the health professions themselves. Thank you.
Okay, so thank you all for participating in this webinar. I think I will finish before giving the floor to Pam to close the webinar with this idea of using the COVID as a transformative opportunity, so that we hope that this changing that COVID is bringing to all universities and to all of us, the good ones, they'll stay. One of my fears is that once we go back to some normality, some of the changes for good in the way we educate, in the way we think about the community work, etc., go back to where we were. So I hope that this don't happen, and we, for once, we learn the lessons and we build upon, I think, that's mentioned, many of the speakers mentioned about this document about the Lancet Commission. So I think that's a good opportunity that COVID helps that make true. No? So this idea of a global community of learning. So Pam, the floor is yours if you want to close the webinar. And thanks again for hosting and helping us.
Thank you very much, everyone, for those organizing this, and of course, all the excellent speakers. I think that you have brought a lot of things to the floor, and I would continue to say what Albert said. I mean, we are all responsible for driving this forward and not going back to something again, because there is so much of initiatives, so much of innovation going on now, and we could be the changing agents in this case. So thank you, speakers, organizers, and of course, last and not least, I would like to thank you, Albert, for being the moderator for this session, and I wish you all a good day after this. Thank you very much.
Thank you.
Thank you. Thanks, Pam.
Thank you.
Thank you.
Everyone.